Our learning objectives today are really kind of threefold. First, to understand what those financial impacts of care coordination are, um, to identify them and to allow you to begin to think about which ones are impactful on your particular organization. The second is to talk about how you might forecast the financial impacts. And in order to do that, we'll actually go into a case study of one hospital and how they went about looking at the financial impacts. And lastly, we're going to talk about some of the ways that you can re-engineer the care coordination processes and clinical activities in order to improve the financial impacts. By way of background, Digital Collaboration Solutions is a consulting and services company that specializes in care coordination and patient and provider engagement. We work with hospitals and other healthcare delivery organizations and healthcare organizations to help them to improve care coordination, to optimize the quality of care that they provide to patients, and to help them certainly to optimize the financial side. And we do that through what we call a balanced performance approach, where we look and say, how do the care processes across the different entities, working with the people in those entities so that you can put together an improved, more optimized way of delivering care and helping patients, and use technology the right way to help accomplish that and to help make it so that you can do the best job of delivering the care that you want. To start with, what is care coordination? There's, of course, no single accepted definition, but certainly CMS gives us one way to take a look at it and says that there are three concepts that you really need to think about. Care coordination is about being comprehensive, about looking at all the different services delivered to the patient, regardless of who's delivering it. It's about patient-centered and patient-centric, that you need to think about how are you meeting the needs of the patient so that you can help address whatever ails them, right? And help them across a whole range of life impacts and so forth so that their health is there. And thirdly, care coordination is about a comprehensive understanding that the patient's journey through healthcare doesn't end at any one point, but continues, frankly, forever. And certainly if you're dealing with chronic conditions and things, then that patient is going to be, with you forever. And you want to make sure that the patient and all of the providers involved with that patient have the information and the ability to work together. And that raises many of the financial impacts because you're suddenly dealing with a pretty complex set of activities, as many of you I'm sure know, because for many of you, this is what you do for a living. And those complicated things that you're doing require you to think about who it's touching, and as a result, where are the costs or where are the revenue opportunities. So that leads us into what is the financial impact of care coordination. And we really look at that and say it falls in three broad areas. And we'll go down in detail on some of the things that cause those areas. The first are penalties. And things like the CMS readmission penalty and the value-based purchasing program from CMS both effectively can penalize a hospital or other healthcare entity. The second are costs. And there's a range of costs that suboptimized care coordination can create for various care delivery organizations. And lastly is care coordination can have a revenue impact in a number of ways, and we'll walk through each of these areas. To start on the penalty side, the CMS readmission penalty, which I guess as many of you are very familiar with, can have up to a 3% reduction on your Medicare payments. And that's not just on the Medicare payments for diagnoses that are subject to readmissions, the 30-day readmissions, but to all of your Medicare payments. So it turns out it's highly leveraged. You can have a small percent of your hospital's Medicare reimbursements coming from one of the diagnoses subject to the penalty, but it can hit everything you get back. It's also based not on readmissions to your hospital, but to any hospital within 30 days. And that creates a challenge because the only organization that really has the data is CMS to look back retrospectively and say, where did this patient show up? And so that creates care coordination needs in order to say, can we understand where the patient is, where else they're going, where else they might go, so that we can manage readmissions. A second penalty area is under the hospital value-based purchasing program. This is a very complex program that looks at measures in multiple domains and can do currently up to 1.75% penalty on base operating DRG payments, going to actually 2% in a couple of years. And I show you the 2016 domain weights, and we'll actually look at those in more detail later on. Great. So penalties, the first area of financial impact on care coordination. The second area of financial impact on care coordination is, of course, costs. And there are a wide range of costs that are impacted by care coordination. The first of those is unnecessary clinical procedures. And there's a whole level of research to look at the impact of clinical procedures and unnecessary ones. Journal of American Medical Association in just a bit ago in 2015, back in May, said that 30% of healthcare spending could be eliminated without impact on quality, and that about 15% of patients were subjected to at least one potentially overused procedure. That was back in 2008, so there's some lag in the data. And most importantly, the JAMA article said that this can be addressed, that if you can improve and increase care continuity, that can reduce overuse of procedures. And they go into a great deal of depth about how you can get there, but at its core, better care coordination, better ability to help manage what's going on with the patient across the care continuum can have an impact on reducing unnecessary clinical procedures. The second area is uninsured patients. And uninsured patients, according to a research by the National Bureau of Economic Research, has cost hospitals annually something in the range of $900 a patient a year. And that some 60% of that uncompensated care actually shows up on your hospital's books as bad debt. So if some of you are CFOs, or if some of you are working with your CFOs, what you want to look at there is to say to your CFO, look, what I can impact here is the bad debt line. And bad debt, is a write-off. It has a negative on your hospital's earnings. And if you can help address that by better coordination of care. And what you're doing there is you're reducing things like ER visits or hospitalizations by your uninsured patient base, and that can be a serious amount. I mean, $900 on average, but depending on where your hospital is, like a big inner city hospital with a more disadvantaged population, can get hit that much harder. A third area of costs are various types of pay-for-performance programs. And we see a range of those. Certainly Medicare and Medicaid have a number of pay-for-performance programs which effectively can hit your cost structure, and private insurers will do their own pay-for-performance programs. These programs vary widely, but when it's said and done are typically focusing on some sort of quality or financial measures and asking care delivery organizations to achieve improvement in those measures, or they're going to end up effectively with a greater level of costs or some form of penalty or something like that. And lastly is kind of the big elephant in the room, which is the transformation of our healthcare system to shared risk or accountable care. And of course, Medicare, Medicaid, CMS have been taking leadership roles in driving new types of shared risk, and are on the Secretary of Health and Human Services just recently said that within a few years they want almost all of Medicare, Medicaid reimbursements to be in some form of risk-sharing program. There's so many different types. And that's fundamentally saying that you as a healthcare provider have to get your arms around what's going on financially across the whole care coordination landscape. Because you're going to, ultimately, in one of those programs, you're going to own the cost. If you're doing bundled payments and the patient gets a hip or knee replacement and lands in a rehab facility, that rehab facility cost is part of the bundled payment cost. And of course, there's lots and lots of detail. The big one that you need to be asking and thinking about, are you in an upside-only shared risk model or an upside-downside, with an assumption that over time it's going to become upside-downside. This train has not stopped, and it's going to keep going. and it can have huge, huge cost implications. When you look at the performance of the original Pioneer ACOs, some of them did really well, but a whole bunch of them had real trouble in effectively making money or not losing money as they figured out how to become an accountable care organization. And that's going to impact all of them. The third area of financial impact is revenue. And there are three big areas that we point out that have revenue implications for care coordination. The first of those is under reimbursement. The American Hospital Association, the most recent data that I've seen from 2014 said that Medicare reimburses about 86 cents of every dollar hospitals spend, and Medicaid about 89 cents for every dollar spent. So if you're getting a greater population of Medicare or Medicaid, in effect, you're losing money on those patients. And that reflects the inpatient prospective payment system and how it pays based on adjusted labor and non-labor costs. But one way or another, a hospital is left holding the bag. Now, some of you can look and say, look, I've got a bunch of sunk costs that are there anyway, like beds that I need to fill. But over time, Medicare and Medicaid aren't going to be going with you there. They're going to say, look, if you have underutilized facilities, you need to figure out how to either get them utilized or effectively take them out of service, because they're looking to bring down the overall fixed cost of healthcare in the country. So under-reimbursed Medicare and Medicaid is something you need to think through, and what you don't want to have happen is that the care continuum, the post-acute care organizations, for example, sending patients back under Medicare and Medicaid that effectively leave you holding the bag for under-reimbursed. If you're in one of those post-acute care facilities, what you want to think about is the same thing. Are you getting money, or are you effectively trying to turf them back to the hospital? And ultimately, that means you need to be working closely together with all the participants. Well, the second area is, again, shared risk and accountable care, and we've talked about that, but that is fundamentally going to define your top and bottom line. And as you move to shared risk models, it's going to impact everything financially for your healthcare organization, and key to that is going to be understanding what costs, what's happening across the full care continuum, and can you coordinate and manage that better. And then a third one that we don't think about, but that's going to rapidly become important, is reputation. If your healthcare organization has a reputation of providing great care, if your healthcare organization has a reputation as a place that helps patients, whether with chronic disease or with any disease, through the care continuum, navigates them and helps them to get the care they need, instead of feeling that you've pushed them to the next step, that's going to give you a better reputation, and that's going to lead towards more care, more patients coming your way, not less. And the whole concept of consumerism in healthcare and the increased amount of consumer choice going on in healthcare is only going to make that happen more and more quickly. So you need to really start thinking about the patient as your customer. And in that fashion, how do you manage and coordinate the care so that they want to come to you? And you see magnet healthcare institutions like the Mayo Clinic, for example, where people come worldwide to seek the degree of capability that Mayo Clinic can bring to coordinating care and to helping patients both while they're there, while they're in post-acute settings, and while they're back home. And that's what you have to think about, and that's going to have a revenue impact. So if we understand that those impacts are there, then we can say, how do we get our arms around it? What should we do to manage and to improve those financial impacts? And then we'll take a look at a case study. So on managing and impacting that, we look and say, you've got to think about touching the whole component, all the major components of delivering care, what we call delivering balanced performance. And it starts with people. You have to recognize that care is delivered by a wide range of people in all of the different care institutions and organizations, and that care is also actually completely intertwined with the patient, with the patient's family and friends. And especially as we try and move patients out of inpatient facilities of various sorts, we rely that much more on patients, family, and friends for quality delivery of care. And we rely on organizations and caregivers that you got to put more in the forefront, like home health care or visiting nurses. The second thing is you have to get all of the people involved in, and back to people, another comment I'll say in a minute, is you have to recognize that it's a broad set of people. It's clinicians, it's administrators, it's staff, it's financial, it's all the people. And we'll go through, you have to take a look then at the processes and what these people are doing. You have to understand how technology can help them. And then lastly, you have to know what you're measuring and understand the goals and metrics that you're putting in place. So starting with process, if you take a look at the process that you do to deliver care, and you think about, can I make that process focused on the patient so that it coordinates the work of the care team, all the care team, patients, physicians, family members, lay caregivers, everybody, then you begin to say, how do I re-engineer and rework that process to do a better job of helping the patient, and to do a better job in the process, as I do that, how do I do a better job of managing the financials? If I can reduce through better processes unnecessary tests and procedures, then I've hit a cost area. If I can understand what's going on with the patient and provide them better post-discharge adherence capabilities through, say, visiting nurses, then I can reduce readmissions. If I can touch on helping them with wellness programs and things like that so that they don't come back with another MI or another heart failure problem, then I'm going to have a greater impact on my value-based purchasing numbers, as we'll see. If I can do that in a way that the patient says, yes, this is really helpful, I like this, then I'm going to improve my patient satisfaction scores, which impact you in a range of ways. So thinking through the processes, engaging all the different people involved, and doing that in a systematic and thoughtful way is something that can have a real impact. And that leads us to people. The care coordination team is complicated, and it crosses all the different entities and all the different types of people and organizations. And what you need to do is align that team and ask, do you have the right people involved in the integrated plan? Do you have the right organizations involved? And some of the best practices are to involve all those participants, to be broad-based when you do this, and then thoughtfully plan how you're going to provide care with the patient as part of that, and then gain support and engagement of all the participants. If the patient doesn't know or understand what they need to do to care for themselves, then you have to find someone who can help them do it, or they're in effect going to get ill again, and one way or another going to be back in the hospital or having degraded health, or worse yet, the immortality. So care coordination, aligning the team around care coordination is essential. And that leads us to technology. Technology is hot. We use all sorts of technology for care coordination. We use electronic health records. We use hospital information systems, mobile technologies, communication technologies, health information exchanges, portals, all sorts of stuff. And I mean, today, Athena Health announced a free secure text messaging service. And that's great. It'll help people. And there are more portal providers out there, and we can get excited, and you can get excited about any one or many of these technologies, and they can help. But what we really want to remind you is to think of technology as a tool. It's a tool to improve things like transitions of care and to lower readmissions, but that it has to improve the processes and it has to support the people. So don't just use the newest hot technology for its own sake. Use it because it's going to help. Though we certainly will say these technologies are having enormous impact. The explosion in use of mobile technologies and things like that. We did some work with one hospital looking at post-discharge adherence and reminding people of post-discharge plan adherence things. And we were shocked to find that text messaging was by far the most widely wanted and used way of doing those reminders, including from the elderly, which surprised us. But everybody's text messaging. Everybody's doing that on a mobile device, and you can, grab on and use that. But at the same time, you have to recognize it needs to be part of that balanced performance approach. So the balanced performance model gives you a framework to help you think about how do I re-engineer and rethink how I'm going to deliver care in a way that I can optimize care across the whole care continuum, improve care coordination, and as a result, go back and impact those various financial factors. And you can tie to any one of those financial factors and say, which of these of the care processes and care activities impact that? Who are the people involved? And how can I optimize that and use technology to help? So an example is often speaks 1,000 words, and so I'd like to look at a case study, in this case a focus on care coordination's impact on the hospital value-based purchasing program. This is a real hospital, but due to confidentiality, I can't name the hospital, and we've actually tweaked the numbers some so that there's nothing here that would give away who this is, because they want to keep this confidential. But in this case, the head of care coordination in this 350-bed hospital in a major city was proposing a comprehensive care coordination program to the chief executive officer, and laid out a full range program that touched on the people, the process, and the technology. So for example, they wanted to increase the case management staff in the ER and make sure that they had good coverage of case management in off hours, because that's when you're trying to move patients potentially not into the inpatient setting, but into somewhere else in the care continuum, but you had to manage that well. And if it happens in the middle of the night or it happens on weekends, it happens. But that, of course, meant having staff to do that. The care coordination had wanted more care transition coaches so that they could work with the patients and families. They wanted a patient advocate. So they wanted investment in people was the first area. The second area was they said, look, we know we need to do those investments in people, but it also means we need to do some of the process work to help make that successful. So they wanted to do things like a transitional care clinic where they could work with patients in a structured setting. And they're getting some of this, by the way. This is all in process. So this is kind of a real-time case. But, a care clinic to work with patients. They want to look at doing a pharmacy delivery program so that patients have medication right as they're discharged, so delivered to the bedside. And they, based on that, then they, have a much higher adherence to post-discharge med programs. They wanted to be able to communicate well with providers and had a whole initiative to do post-discharge provider communications so that they could make sure that the various players in the care continuum were engaged and involved. And they were looking at some exciting technology ideas, like using heart failure monitoring technology from a company that they said would really allow them to know if patients were getting into trouble because they had a reasonable amount of heart failure patients. They wanted to do a reminder model for post-discharge care plan adherence using some technology. And this isn't everything they had. This is a bunch of highlights of the kinds of components of the program that the care coordination head was proposing. Well, their justification, when it was said and done, looked mostly financially, that it was going to come out of the hospital value-based purchasing program, and for them also some out of the Medicare readmissions penalty. So the methodology that they took, and we worked with them on this financially, was to forecast the financial impact of improved care coordination on those two areas, on value-based purchasing and on readmissions. And to do that, we had to analyze the 4 value-based purchasing domains that you can see on the right there, and I'll talk about more in a minute. And then in those, look at the measures and focus at the measures that were impacted by care coordination and say, look, here's where those measures are today. Here is some things we could do in the people, process, technology, balance, performance to improve those measures. Here's a projection of what they could be, and here's a resulting financial impact of improvement of those measures. And the financial impact was, how would it change the value-based purchasing penalty or reduction in reimbursements? So for those who aren't familiar with it, the value-based purchasing program has a pretty complicated measurement structure. it builds a weighted score based on measurements in a number of domains, currently 4, kind of going to 5. And based on your score, there's a comparison to, if you like, peer groups and so forth that determine a particular hospital's reimbursement reduction. As I said, it can be right now up to 1.75% heading to 2. And then to make matters more confusing, there is incentive earn back. So the better performing hospitals, in effect, get some of the money given up by the lower performing hospitals. So if you can get on the better performing side, you get a double win. So they leverage that, if you like. It also makes it that much more complicated to analyze and understand and forecast because you have to make some assumptions, especially about the earn back program. So within that, CMS looks at 4 broad domains, what they call the process domain, the patient experience domain, the patient outcomes domain, and efficiency, which in this case is really measured by MSPB, Medicare service payments per beneficiary. In each of those domains, there are multiple measures. So some of them have as much as like a dozen measures that they follow to get at the domain score, which then feeds into the top financial impact score. So we're not going to go through all of that. We'd be here for hours. We're going to kind of pick and choose our way through examples of some of this analysis and scoring. So to start with, this hospital looked across the 4 domains of process domain, patient experience domain, patient outcomes domain, and the efficiency domain. And you can compare their performance in fiscal 15 to fiscal 16. And you can get a feel for if they could achieve particular improvements to the score, they had the ability to save really a rather modest amount that we were surprised, but a couple $100,000 a year on just dollar savings from value-based purchasing and from the readmission penalty. Now keep in mind there are other benefits of revenue improvements, the other financial impacts we talked about, but we focused in this analysis especially at the value-based purchasing one and the readmissions one. So by moving the needle of those performances from, say, 40% process domain, they were estimated down and so forth, but moving the needle, you could have that sort of financial impact. And when you take a look at which domains are impacted by care coordination, some of them are not. So the process domain are all in acute setting processes. What did you do when the patient arrives kind of thing, and in general are not impacted by care coordination. So none of those we took a look at. Patient outcomes, some are and some aren't. So mortality, some of those things are outcomes that you can feel are impacted. Efficiency certainly is. Some a patient experience is and some is not. The question, HCAHPS questions about things like, did you like the nurses in the hospital? Probably less impacted. But did you get good discharge instructions? Certainly could be impacted by what happened post-discharge and your ability to work with them. And as you see, the readmissions penalty in this case also had some real potential opportunity for them to save some money if we could manage care coordination better. So with those 4 domains, we'll take a look at one domain, the patient outcomes domain. And in 2014-15, there are, well, it all keeps changing. These are the measures that are being tracked to determine the patient outcomes in the value-based purchasing program. So 30-day AMI mortality, 30-day heart failure and pneumonia mortality, and then in 2015 only, certain selected complications measures and central line associated bloodstream infection measures were all part of the outcomes domain. It turns out in 17, these are changing yet again, as are the weights on these areas. So if you go back here, it shows the 2016 value-based purchasing domain weights, and the CMS keeps changing the weightings and moving them around to push people to take the actions that they'd like to see. So these are the example measures in the patient outcomes domain, and they're scored by looking at the hospital's performance in each measure and looking at relative to benchmarks and then determining if the hospital both achieved the benchmark, meaning the top end of performance nationwide, and if they had made improvement. And if you got either achievement or improvement scores, whichever one of those the biggest determines your value-based purchasing score in that particular measure. And that, of course, rolls up the domain. It's weighted by the domain and rolls up to your total composite score. And we'll show you an example in a minute because the computations are complex and require getting some real data here. But when you have them, you can get a pretty good handle around what's going on from a value-based purchasing impact on, from care coordination. So let's now take, and in that patient outcomes domain, look at, again, one example, MI 30-day mortality. And what you can see here for this one was in the baseline period, the number of cases and the score that they had for those cases, and these are all very tightly defined. In the performance period, number of cases and score once again, and then the national performance standards that they used. And based on that, they had limited improvement, but they did well on achievement. These cap out these numbers, the points earned at either 9 or 10, depending on which measure and domain you're in. So in this case, 8 is greater than 0, so they got 8 points based on achievement in the 30-day mortality measure. And that measure is quite clear. It's AMI 30-day mortality. In this case, they flip it and they use survival rate is the actual number. So this is the survivor percentage that you're looking at. You compute both the achievement and improvement scores, and then you get to pick the better one to use as your scores for this, your points earned. And you effectively add these up across the measures in the domain. So in the case of patient outcomes, you add them up across right now 3 measures. Soon I think it's to either 4 or 5 measures. They're adding some back in, and in 15 it was 5 measures. You add those up and then you weight them by the domain weight, and they feed into the overall score. So understanding which domains matter to you and which domains are impacted by care coordination, and within that to understand which measures are important and to take a look at how you're doing against these measures. Is this a measure that you've had really, really good performance? Is this a measure that you're having weak performance? And which of the measures are going to have an impact that you can change, that you can move the needle on? And that leads towards building your financial justification. So in effect, you want to forecast your VBP, if you like, penalty. How much are you going to get your reimbursements from from CMS reduced? You then want to understand the cost of making change and compute a return on investment to say, is it worth it? And your decision is based on a couple of things. This is sort of Finance 101 if anybody's taken a finance course. One of the things you compare it to is what's called a hurdle rate. Is the return achieve what your hospital feels you need for a return on investment? The other one is, how does it do relative to other uses you could have of funds? Are you better to go and do a different program than to try and do whichever thing you're saying is going to help in value-based purchasing? And which one gives you a better financial break-even? Now keep in mind, or financial return. Keep in mind, that doesn't mean that financial numbers are the only decision criteria. You want to do the right thing for patients, you want to do the right thing for your reputation, and you could choose to do something that's not maybe the best financially according to all the numbers, but for a set of non-financial reasons is still the right thing to do. So a short case study, in this case, an article out of Health Affairs magazine that looked at a group health cooperative, a nonprofit care delivery system in the Seattle, Washington area, and they had used a medical home care delivery redesign approach, effectively saying we want to use the ideas of patient-centered medical home to coordinate care across the care continuum, and to really use that as their framework, their process framework and their people framework to say, how am I going to manage care across the care continuum? And when they went in and took a look at that, they found that they could save something in the range of $10.30 PMPM per member per month, and that gave them a break even of something like 21 months at a 1.5 to 1 return on investment. So for every dollar spent, they would get 50 cents more back, or $1.50 back. And from that point of view, they said going to this medical home care design approach to care management and managing care coordination had positive financial returns. So they didn't use the VBP program as our other case study did. They went and looked at it in sort of a total savings basis. But that comes back to which of those various financial impacts are the one that matter for you. If your Medicare, Medicaid reimbursement is really high, things like value-based purchasing could have an enormous impact. If it's smaller, you have a lot of private pay, then it might not be as high, but saving money could make sense. If you're seeing a fast movement towards shared risk, you have to understand your shared risk numbers and how that's structured, because that's going to make or break the finances. If you're still seeing lots and lots of fee-for-service, you might look at some of the other areas of measurement. So what do we recommend as action steps? The first of those is identify the financial impacts that matter to your healthcare organization. And the methodology that we would suggest there is to step back and review historical financial results. You've got the data, or if you don't, get the data so that you can look and say, where are we doing great? Where are we not doing great? And based on that, where do we think we could have the most impact? In a sense, sort rank them. And we actually know some methodologies that can help you to really, as an organization, to look and say, what are the areas that we could do? What are the initiatives? How do we, in effect, stack rank and decide which initiatives are most value, and then drive them to ongoing implementation and results? Once you've identified your initiatives, then go and say, well, what's it going to cost me to do something, improve them? And what sort of savings can I have? How can I reduce penalties? What the revenue can be? In effect, to do what we just showed you that this unidentified hospital did, where they went and said, look, we can move the needle on value-based purchasing in the care outcomes area. Once you have that, then third, compute the return on investment and make sure that your CFO is going to do this. There's a CFO on the line. Hopefully you're nodding yes. That, is this the best place to put my money and best place to put our limited staff resources in making change? Because there might be other things that are more beneficial for your particular organization. But if it is, then you can say, great, we're going to go move forward on this, and you need to implement the changes. And that's, of course, key to success. Because I can give you the best case, financial case that says this is where you're going to have impact and this is how much that can be. But if you don't implement and make that take effect, well, clearly you're not going to have those savings. And to do that, we're back to that idea of people, process, and technology balance, and that it's all about the details. It's all about good project management. It's about aligning the individuals to new processes, using technology if you're going to, and if it makes sense, the right way. Then you will get the return on investment that you projected and have good results. So in summary, care coordination can have huge financial impact on your healthcare organization. It can do that, as we said, through the areas of penalties. It can do that through costs and cost management and cost reduction. And it can do that through various ways of revenue enhancement or avoiding revenue loss. And to do that, you need to methodically go through these action steps to understand the opportunities and the potential return on investment of improving care coordination in whatever way makes sense so that you can impact any one of those measures.